Hi, everyone. We are scheduled to start at 1 o'clock. It looks like we have a few more attendees jumping onto the webinar right now. So we will wait another minute or so and we will get started. Thanks for your patience. Okay, I think we are safe to get started. It is 1:02 at least in Texas. So um, good afternoon to those on the East Coast. Good morning to those on the West Coast. Hope everyone is doing well, having a good Monday. Thank you for joining today's webinar with Homecare Homebase and our partner Swift Medical. We are very excited to have our customer base join the webinar to learn more about our partnership and how Swift works with Homecare Homebase. Today, I have the honor of introducing our two panelists, Sandy Griffiths, our Senior Product Manager at Homecare Homebase, and Amy Casada, the CNO and Senior Vice President of Customer Success at Swift Medical. Sandy is an experienced healthcare IT professional with an emphasis on product management and agency operations in a regulated healthcare environment. Sandy is passionate about the clinician's experience and collaborating with stakeholders to identify business challenges and opportunities to solve them. Her extensive healthcare technology experience includes agency operations, system implementations, training and support across project life cycles, as well as product management throughout the software development lifecycle. So very happy to have Sandy join us today for today's discussion. Amy Casada on the Swift side is a Chief Nursing Officer and Senior Vice President of Customer Success, as I mentioned, where she leads clinical strategy and the team supporting thousands of providers using AI-powered wound imaging across post-acute home health, hospice, and hospital care. Her career began along bedside caring for complex wound patients, and she has spent more than 20 years in the intersection of wound care practice and the operational systems that determine whether good care reaches patients. She works alongside national provider organizations and clinicians to build digitally enabled wound care programs, and she is passionate about technology and driven strategies that improve patient outcomes and strengthen the clinician experience. Amy is a published author in peer-reviewed literature and frequent speaker at national healthcare conferences with deep experience in wound care operations, clinical program design, and technology adoption at scale. I will turn it over to both Amy and Sandy to lead the webinar.
Thank you, Matt. So welcome everyone for joining today. Just really quick, here's what we're going to go through. First, why good wound care technology goes unused. Not really whether it works, whether it gets used, but the friction that quietly turns into a purchase that sits on the shelf somewhere. Second, we're going to go through the integration itself. We'll show you a demo of the solution going from point care into Swift and back into Homecare Homebase in the same workflow that your nurses already use. So stay with us through that middle part. That's really the part that you came for to see how the solutions work together. And third, what does this really mean for your agency? Adoption, staffing flexibility, wound care data that you can actually rely on, and when someone asks you to defend it. We're going to have two quick polls along the way. Your answers will really help us steer where we spend our time. And then again, one question, the theme that really runs through all of this, and I'll keep coming back to it, is will your actual nurses use it? So with that, we're going to go ahead and jump into our first poll question. So everyone should see a pop-up appearing for the poll. We'll leave it up here for about a minute. But again, what is the biggest reason technology fails to stick with your staff? And again, this does not need to be wound care technology. This is any technology that you're adopting with your organization. Is it too many clicks or the steps that the clinicians need to do at the visit? Is it because it lives outside the chart? Is there not enough training or reinforcement? Or staff do not see what they get out of it? So we'll let you take a few more minutes to answer the poll. All right. So it looks like we have the responses for our poll. And the number one reason that the organizations it's failing to stick with your organization is too many clicks or steps during that visit. And then a tie for the information lives outside of the chart and staff do not see what they're getting out of it. So great responses to that. We're going to kind of cover each of those through the session that we're going to go through today. So why is this decision different than years before? Before we talk about wounds at all, I want to name the year that you're buying in because the money's already decided. The only variable left really is the execution. We all know that CMS finalized the 2026 home healthcare rule on the 28th of November last year. Aggregate payments are down 1.3%, about $220 million against 2025. And honestly, that was a reprieve. The proposed rule back in June had a 6.4% on the table. That's roughly 1.1 billion. But here's where the part that matters. This is the fourth consecutive year of permanent cuts. Those permanent behavioral adjustments were 3.9% to 2.9% and then 2.0 and now 1.0. And with a temporary adjustment of about 2.7% layered on top of this, that 30-day base episode rate is about $2,038, which is down from $2,057. So your unit of revenue is flat, so slightly down, and your wages and supplies and fuel are not flat, right? They're going up and sometimes exponentially going up. And that's one line I want every finance leader to hear right now is agencies that fail to submit required quality data to excuse me, agencies that fail to submit required quality data take an additional 2 percentage points of reduction. So documentation is not administrative overhead. Documentation is the rate. Incomplete wound care documentation is a revenue event, not just a charting problem. The National Alliance for Care at Home has said plainly that even with the final rule divided, reduced patient access and agency will drive reduced patient access and agency closures, which means that every financial lead on this call and every financial lead in an organization has already been asked to defend a software item, line item against that backdrop. Now, flipping to my clinical side, because that's where I've lived and breathed for many years, wound volume is moving in the opposite direction of the money when you think about it. Chronic wounds roughly affect 1 in 6 Medicare beneficiaries, about 10.5 million people, and that's conservatively. An estimated $22.5 billion a year on Medicare. Prevalence among those beneficiaries rose 13% over 5 years from 14.5 to 16.4% and grew fastest in beneficiaries under 65. That's the population you keep at home the longest. Meanwhile, home health agencies' wound expenditures fell from 1.6 billion to 1.1 billion over that same period. Think of those two facts together. More wounds, more complexity, less reimbursement flowing into the setting that's actually doing the work. The gap does not disappear, it gets absorbed by your nurses. The stakes per wounds are not small. Pressure injuries are showing up in about 5% of patients receiving community nursing care. Medicare roughly spends about between 300 and $3,700 and $4,000 per beneficiary for a pressure injury, and about $9,000 to $9,500 for an arterial ulcer. A missed stage wound is not a small clinical variance. It's an expensive trajectory. So here's why I put these two columns side by side. Wound documentation is one place where the clinical record and the financial record are literally and can be considered the same document. The measurement and the image drive the OASIS coding, the case mix. They drive whether a wound trajectory holds up in a review. They drive whether you can prove the care that you actually delivered was delivered, which means when a wound tool does not get used consistently, your nursing lead or your chief nursing officer loses clinical visibility, and the financial lead or your CFO loses defensible documentation and loses money at the same time for the same root cause. This is why the rest of this section is about adoption, not features. In a 1.3% year, a tool for your staff to work around is not neutral. It's a loss on both sides of the house. So I want to be careful here because this slide is not a criticism of anybody's clinicians. 4 words, and one of each of those cause the next. Subjectivity. A paper ruler depends on who's holding the ruler, how the ruler is orientated, where that person decides the edge of the wound is. 2 experienced nurses, 2 wound care expert nurses can measure that same wound, write down 2 different numbers, and neither of them really was careless. Inter-rater liability variation in manual wound measurements is well documented, and it's a limitation of the method of manually measuring a wound. It's not a problem in effort for the clinicians that they're actually doing it. Invisibility. If there's no image, nobody downstream can audit the call that was made. Your clinical manager reviewing the chart is not reviewing a wound. They're really reviewing numbers and a subjective assessment that a nurse documents, assuming that nurse documents everything that he or should be. Unprovable. So healing in a decline lives in a narrative note, maybe a structured note, but it lives there rather than in the evidence. And that's completely fine, right up until the moment somebody asks you to show that. Costly. And this is really where it lands. Missed deterioration, missed infection, missed wound dressings show up later as an avoidable hospitalization, an unplanned physician's visit, an unplanned ER visit, or an audit and a finding. And one of those costs more than the documentation would have ever had. So I ask you to step back for a second and really think about that. Wound trajectory is the entire clinical question. Not what the wound looks like today, not which direction is it moving, but if you cannot compare visit to visit reliably and between different staff, you cannot tell whether the plan of care is working. And early is the only point in which intervention can be cheap. For scale, just for thought. Chronic wounds affect roughly 1 in 6 Medicare beneficiaries and cost Medicare, again, like I stated, over $22 billion a year. And again, pressure injuries spend average is about $4,000. Again, somewhere between $3,700 and $4,400 per beneficiary. Objective measurements is how you influence which side of the average your patients end up on. So let me say the uncomfortable vision. This is not a staffing effort problem. It's not a measurement problem. Your nurses are documenting exactly what you asked them to document. The tool they were handed simply cannot produce evidence. Going back to what I've always said is you cannot manage a wound, you cannot measure right? That you cannot measure, and you cannot measure that wound the same way twice. So as we continue to look on, where do we lose that wound evidence? Again, thinking back to the poll that we did, the results are interesting. It kind of lines up what I just showed with you. You just told me where the technology breaks down for you. In each organization, it may break down in a different area. This slide is where the wound record breaks down today. And I want to be precise about the current state because most of you live in it. A nurse measures with a paper ruler by hand, by eye, and types the numbers into their chart. There's no image. If you're lucky enough to have an image, there's an image, but there's no reference, there's no association with it. And it can be super close, it can be very far away. And we know we all see lots of different things in those images. And there's not a second tool to blame. It's just the workflow. So when we think about how we're doing it now, we're assessing that paper ruler is operator dependent. Again, I can measure a wound, another nurse can measure the wound around the same with me, and neither of us are being careless. It's how we were trained and how we use the ruler. That record, the moment the numbers are typed, it becomes only visible, it becomes the only version of truth. Nothing behind it can be checked because there's nothing behind it to check. So now when the next nurse comes after me and he or she is reassessing, that next clinician inherits a number without a picture. They cannot visually see what the wound looked like at the last visit. So they're not continuing an assessment or an evaluation. They're restarting from scratch. How often does the same nurse see the same wound twice in a row, right? That's the ideal scenario, but we all know in the world that we live in, it's not always how it is. So then we think about the end, defend, right? We know that healthcare, unfortunately, in the US is very litigious. And many different audits are happening. So if you're in a review or an audit or on a call with a physician or in your weekly case conference, progress cannot be asserted, but it cannot be shown. The moment this becomes a clinical gap, it becomes a financial gap too. Every step here is documented. None of it is verifiable. Let me ask you something honestly. Most of you have already had wound assessments or imaging policies on the book. The real question is whether your workflow lets staff follow those on a day-to-day visit and follows those on a full day of visit. Because policies do not fail because clinicians don't care. Those policies fail when following them costs the nurse more time and effort than he or she has in their day. So if you're the nursing manager, without a baseline image, you cannot verify staging. You cannot trend healing objectively across clinicians. You generally cannot tell whether variations in your outcomes is patient acuity or measurement inconsistency. If you're looking at from a financial perspective or the compliance perspective, those wound measurements feed your OASIS, coding, and case mix. An unverifiable measurement is an undefendable claim, and quality data submission carries its own payment consequences, and 2 percentage point reductions for agencies that fail to submit. If you're running from the operations, when capture is fast, objective, and the clinician already is standing in the home and can do it, when it's slow or subjective, you end up routing a wound specialist or a second first nurse to go in for a revisit just to get a verifiable understanding of that wound. That is where the staffing costs create by documentation is the gap. So before I hand it off to Sandy, we're going to do 1 second little poll, and then we're going to actually show you the workflow. So our next poll, again, is where does your team face the most friction with wound care documentation today? And again, you should have the poll on the screen. So again, is it capturing consistent wound measurements, the documentation, comparing progress from visit to visit or clinician to clinician? Or is it simply getting those clinicians to follow the wound care documentation process in general? Give it a few more seconds while people submit their responses. All right, and our poll results. So it looks like half of you are saying getting clinicians to consistently follow the wound care documentation process is the number one friction with your wound care today. So as I turn this over, before I turn this over to Sandy, we're actually going to show you how the integration works, and that will mitigate or some of those concerns that you have regarding the documentation and the flow for the clinician.
The integration between Swift and Homecare Homebase enables the seamless exchange of wound evaluation data and images between the platforms. Welcome to Point Care and Swift integration. Accept your visit and sync. Start your visit. Select visit actions. 2 actions are required for orders to appear in Swift. Diagnosis and pathways. Approve the diagnosis. Then you can move on to pathways. Select diagnosis and approve. Select pathways and complete the initial orders. Any wound care orders must have the wound-related checkbox selected. Select ICC. Select Document. Select Wounds Present and you will be brought to the Swift's patient record. Patients in Homecare Homebase are automatically synced with Swift. No double documentation required. This will open the Swift Skin and Wound application. Complete your wound evaluation until you reach the Orders screen. Select the appropriate order from the list. Complete all required clinical documentation by scrolling down and clicking Document. Wound care provided is autofilled with the selected wound order. Finalize your documentation in Swift. In Sign and view your evaluation. This will push it to Homecare Homebase. Click the back button to navigate back to the Swift record and then back to Point Care. Upon completion, you will see a green check mark in the document area. Upon opening wound care orders, you will also see the additional green check marks for orders, assessment, and wound care provided. The green check mark appears now that all documentation is complete. At this stage, complete the plan of care. Plan of care development must be completed, and the Contains Wound Care Orders dropdown should be marked as yes. Once the visit is complete and synced, all data and images documented in Swift will appear in Homecare Homebase.
All right. Um, So that is kind of how the workflow happens and flows from Homecare Homebase through Point Care into Swift. So I ask that you, if you have any questions, please use the Q&A section to leave any questions that you have. But I'm going to pass it over to Sandy now to round out the last few slides.
Great, thanks, Amy. So let's go back and review what we've seen through the demo here. So some important key features on here. At least one wound order must be flagged as wound related in order to launch Swift. We have to know that we have some wound care orders for those wounds to make sure that your clinicians are following that wound care. Remember, one of the things that was mentioned was following your processes on there. So we are using the exact same workflows and steps that they're used to now. Going into ICC, launching ICC, in a starter care visit, confirming that wounds are present. If it's not a starter care visit and we know that there's wounds in the wound record, they don't answer that wound's present each time. So they launch. Then the order then is automatically linked to that wound. So we know that every wound has an order. And then the wound care provided text, similar to what they did in Legacy ICC, ensures that the wound care being provided, what they're documenting they did, actually matches and aligns to that order on there. And then the amazing thing, of course, is the measurements and the documentation and the images, because all of that is captured right within the Swift application, automatically is all captured together. When the completed visit is synced, we'll bring back both the documentation from Swift as well as the visit note. And then the image and the measurements and the documentation are all still embedded within that visit note on there. So while you have two systems, you still have that one thread. The order, the image, and the note all stay together on here. So in some ways, let's kind of think about what changed between what their clinicians are used to doing today and then what changes in Swift. They're still starting their visit, they're still completing their visits. Today they're measuring wounds by paper and all the fun things that Amy mentioned in terms of things that contribute to inaccurate measurements. And then with Swift, all of that is going to be handled automatically through capturing the image, the measurements, and linking to the orders in there. So the big thing, of course, they have that image on there. And because the image and the measurements and the documentation is all together in there, you get much more consistency. Even it's the same nurse, the same visit, but now there's a picture behind those measurements and the ability to identify that progress is much more impactful. So what we have here is one story, but three different payoffs for the executives and the agency administration. The adoption turns to from a software spend to a realized ROI. So it stops being a question about what does it do and rather does it get used, because it's automatically going to get used in there. For operational leaders, there's less workflow friction and more staffing flexibility. The right clinician can capture and document right at the point of care. And then for clinical leaders, your nurses are not fighting just another disconnected system that they have to go out to. We're managing their time, their documentation, quality, and the morale.
Thanks, Sandy. So before we open it up for questions, and I think I'm seeing some questions already coming in on our side, I really want to leave you with this one sentence. This whole session was really built around. Adoption should not be an afterthought when you're looking at technology. It is the technology decision. Everything we walk through comes back to that. A tool that measures beautifully, does not get open, produces the exact same wound record you have today. A number with nothing behind it And again, where a year where CMS finalized a 1.3% aggregate payment cut, again, that fourth consecutive year, unused software is not a neutral line item. It's a loss on both sides of the house from the clinical side as well as the financial side. So again, take one thing to take away is when you evaluate wound care technology, ask where it lives in the visit before you ask what the feature it has. So with that, I think Matt's going to be joining us and kind of spearheading the Q&A.
I am back, but my camera is not working. So give me 1 second.
So while he is doing that, I can see one question is what happens if the physician order says assess and treat? So you would follow your current clinical process. That assess and treat order can come through, kind of what we showed you, it would come through. And then in the actual wound care provided, the nurse, he or she can document what the actual wound care provided was, and what he or she applied to that.
And if in subsequent visits a new order is written that is more specific, once
Mhm.
that new order is written, then that wound can be linked then to that new order. So you always have the correct order linked to the wound there.
Mhm.
That's great. And Amy, thank you for taking that on while my camera was having some difficulties. Maybe another question that came through, and maybe this is a little bit of for both Amy and Sandy. What setup has to happen in Homecare Homebase before a clinician actually uses Swift during a visit?
I'll let Sandy start with that
Okay.
one.
So the main thing is your organization can already identify for your staff which orders are wound related. So if you think about going through your pathway interventions, you'll have orders that are, provide pressure ulcer care, provide surgical incision care. You can go ahead and in the pathways builder, automatically set those items up so they're wound related. That way, when your clinician goes to create that order, select that pathway, update their intervention text, that will automatically be selected, so will automatically flow to Swift on there. If it is one of those more generic ones, like the example used before, assess and treat, they can always check that wound related if it's not the standard type of order that you would be expecting. Amy, you want to add any more?
No, I think that kind of sums it up. And then just before a customer would go live for integration, we support both Homecare Homebase and Swift supports, making sure that they're all there. So as soon as it's turned on, those orders are already flowing right in for the nurses at the bedside.
Perfect. Well, maybe one for Amy for you to answer. If a clinician realizes after the visit that something was documented incorrectly, how are corrections handled?
Um, so corrections are handled a few different ways, and it can be handled within the policy and procedure of your organization. So if the visit is not closed, so if the point care visit is not closed, they can adjust the information within the Swift application. If the visit is already closed, obviously they would do a care coordination note to adjust it after the fact. And then on the next evaluation, something could be adjusted. So maybe, for example, it's a stage 3 and they documented it's a stage 2. So the next time that they're going in there, they can adjust that documentation and just have that care coordination note happen before. Sandy, anything else?
No, I think that just follow your usual documentation processes.
Okay. Another documentation question that came in. Does all documentation have to be done as they are with the patient, or can they go back to it? I'm assuming.
So no, all the documentation does not have to be done at the patient. There is required minimum documentation. So essentially what you saw in there is when the nurse goes in, we call it a deep link. So was there wounds present? They say yes, it goes into Swift. As long as they take the image and do the minimum required documentation, which I think is like 5 items, they can save it, go back to point care, put their device down, hands on the patient, full interaction with the patient, go to their car, go back in the same way. Was wounds assessed? Yes. And then they can finish their documentation and go back to get that green check mark. So it allows them that flexibility of when they're in their home, if it's a single wound or if it's 3 or 4 different wounds that they can go between and document later. Um, they do have to finish the documentation to get the green check mark, which allows them to complete the visit and point care. Sandy, anything else that I missed on that one?
Nope, that's it.
Okay.
I think this is a good question for Amy, and it speaks to the value of Swift. Do we need a wound specialist to do the imaging and measurements, or can the field clinician who is already in the home do it?
Yep. So the way that Swift was built is to make everyone a wound care expert. So again, that clinician in the field can take the image and do the documentation. The one piece that we did not show everyone today is there is a whole Swift dashboard as well. So if your organization has a wound care expert or does not have a wound care expert, they can utilize the dashboard to identify which wounds are getting worse, which ones are getting better, um, and to drive down into those case conferences. But our inter-rater liability is 99%. So it doesn't matter if Matt takes the picture, who's not a clinician, or Sandy takes the picture, or I take the picture. Those inter-rater reliability measurements are going to be 99% of the time the same measurements. So again, making everyone that's using it an expert in measuring those wounds.
Just a side note there, my wife would contend that I'm a great picture taker, so Swift would only make it better, which is a good thing for everyone. I think we only have a couple more, so Sandy, maybe one for you on the Homecare Homebase side. Where can our clinical managers see wound images and documentation after the visit?
So after the visit, because it's part of the visit note, they can either look at the visit note within the medical record. So, medical records, clinical input, visit notes, or they can also see the same information in the wound record summary. But you have the added benefit of having the images in there versus legacy ICC. Or look in the portal.
Or look in the portal. Okay. Well, I think that concludes our Q&A. Don't see any more that have come across, and those that have were answered. So I think we're okay to move past Q&A. Sandy and Amy, thank you so much for taking some time and walking through this webinar for the Homecare Homebase customers. Swift is a valuable partnership within the Homecare Homebase ecosystem, and we are happy to be able to present to our customers what our partnership is and how it works, and how it benefits each of the end users in the field. We will have this webinar posted in our CEP for those who have access to the customer experience portal. We'll most likely post it on our website as well. With that, I'll let Amy and Sandy say one last goodbye, maybe, and then we'll go ahead and end today's webinar.
Well, again, thank you for being such a wonderful partner, Homecare Homebase, and allowing us to bring our expertise to your customer base. So if you have any questions, feel free to reach out, or Matt's kind of showed you in the CEP portal where you can find more information. So again, thank you for being a great partner and allowing us to join with you today. Sandy?
And anybody who's coming to Users Conference, we'll see you at Users Conference.
What a great plug. Yes. Excited to see everyone at the users conference in a few weeks. Sandy and Amy, thank you so much for your time. Attendees, customers, thank you so much for joining. We will catch you on the next one. Have a good rest of your week.